Hello. Welcome to Remaking Medicine. My name is Emily F. Peters. We are here once a month to talk about progress, philosophy, ethics, theology, innovation, creativity, everything in medicine and the progress towards a better healthcare future. And I'm joined this week by the wonderful Jacey Cooper, who I got to meet over the spring this year as she was transitioning in her professional life, and just has a wealth of information around Medicare, Medicaid. And so, Jacey, please introduce yourself and give us the story of where you've come from. And I'm so excited to dive in with you today on this topic.
Sure. I'm very excited to be here as well and have this conversation. I have 20 years of experience in dominantly Medicaid, just to be clear. And I started my career in public hospital systems, and I'm really happy I did because it's where I learned that healthcare is a human right, to be honest with you, and it has guided my entire career in regards to how I think about patients, how I think about systems. I've always tried to do my work really focused on the purpose and system fluency. And system fluency might sound like a strange term, but it's really like, how do I take policy and apply kind of operational acumen and design together? And it's how I've kind of approached my entire career. So I'm really excited to be here. I've also worked for the state of California. I've worked for CMS. So I think working at the federal, state, and local level has really just guided my lens of how I've done and built policy over the years.
And this is a moment right now for Medicaid.
Yes.
Everybody is talking about Medicaid, cutting Medicaid, adding work requirements, talking about the impacts of Medicaid in our communities. What is happening with Medicaid? And do you think that Medicaid has a PR problem? Are people understanding it in the right way right now, as it's like in so much of the news headlines right now?
I think the short answer is yes. Medicaid probably has a PR problem, but let me kind of flag some of the reasons why it probably does, right? You are talking about a federal state partnership, which means you have 50 different programs. It's essentially a Medicaid federated maze, if you think about it, right? Everyone covers different benefits, they cover different lives. So it's really hard to tell a national story. And Medicaid uses a lot of jargon, it uses a lot of acronyms, right? And so messaging usually dies on contact with people because Medicaid, like government, I've worked for the government for like 17 years. You don't want me to ever write the communication guide that goes out, is what I would say. And it's hard because a lot of times in Medicaid, there's stigma or polarization tied to it. And so people will caveat the language a lot, or they will be on the defense with their language a lot of times. And I think we have to change some of that. It's not around charity, it's about infrastructure. Medicaid covers like 50% of children, 40% of births, and 35 to 40%, depending on what number you look at, people with disabilities. That's an entire health infrastructure program for the entire nation, right? We just have to talk about it differently. And it's been a problem for a long time about how we talk about it. Instead of it being a dependency, it's more around resilience. It helps families bridge income dips and get back to work and keep workers healthy. Unfortunately, for a long time, we have not been great messengers. I think we're too wonky policy people that we really need to hire, professional PR firms to help us communicate how we talk about these things, to be honest with you.
Yeah. And go back, for those of us who know a bit about Medicaid, talk about, its journey very briefly over the last now 75 years, right? 100 years almost, of starting out as a program was fairly limited in the initial. Is that true? And then has grown and changed over time?
Well, not necessarily. I mean, Medicaid, if you look at straight numbers, yes. I think when in 1965, there's probably around 4 million lives, and now there's like 85 million lives.
Yeah.
So, but you have to look at that in context, because if you go back to some of the origins of Medicaid, it was meant to essentially provide coverage to people in two different groups. So either had categorical eligibility, so someone with a disability, for example, or foster youth, or you had income-based eligibility, so under a certain income, And the goal there was really for families who had lower incomes to be able to afford medical services.
Mhm.
And then there was one other group was kind of event-based eligibility, also tied to income. And that's like if you're pregnant, you can get
Mhm.
eligibility, right? So that has been pretty consistent across Medicaid's entire tenure. What happened in the ACAs, we added adults later.
Mhm.
So yes, that is the expansion. But I think what people often don't realize is Medicaid's growth is tied 100% to the economy. So if the economy is doing well, people are doing well, wages are up, they have less reliance on Medicaid because
Mhm.
of those two groups, categorically, it's about 20% people. Income based is about 80% of Medicaid. And so you're really going to see changes on that front
Mhm.
when directly tied to the economy, if that's helpful. And yes, they have probably covered more services over
Mhm.
time. Sure. But that's because those services are addressing core problems. So, for example, if you cover individuals with disabilities or elderly individuals, you want them to be able to safely reside in their home and not be in an inpatient stay or a skilled nursing facility.
Mhm.
So, back at the beginning, they probably were languishing in inpatient beds or in skilled nursing facilities, but over time, we've added benefits to keep people in their home and decades of evidence that shows by doing that, it's actually less expensive to keep someone in their home with some wrap services around them than putting them
Mhm.
in a skilled nursing facility, which is very expensive for the record. So yeah, I mean, Medicaid has evolved, but at the end of the day, it is a core, program for most Americans, to be honest with you, at some point have been on Medicaid or know family members that have been on Medicaid.
Mhm. What are some other misconceptions that you hear all the time about Medicaid? I mean, one for myself, I didn't realize that the rate of people who are working on Medicaid is already very, very high, right? When we
Yeah.
talk about adding on work requirements, it's like 70%, something like that?
I
I
think,
should know
yeah,
the number.
the
Yeah.
estimates vary. Some people are saying, anywhere from like 64 to 74% of
Mhm.
people are already working in some capacity. And then if you add the exemptions, it can get really high in like the
Mhm.
90 to 95 or 92%
Mhm.
of people that would be either working or exempt for work requirements, for example, that's being talked
Mhm.
about. So what people have to remember is most people in Medicaid are usually on the cusp. They're families that are, yes, lower income, and they may fluctuate
Mhm.
where they will come in and off Medicaid based on that income fluctuation or life changes that happen to them. And that's a big chunk. Very few people in Medicaid are kind of on it for a really long period of time, more than 5 to 10 years. And that's going to be categorical eligibility. People with a disability that doesn't allow them to work and have Medicaid for a longer period of time, as an example. So yes, I think that is a great example of misconception of people on the Medicaid program. For
Mhm.
example, I was on Medicaid, right? I when I had my twin girls at 21 as a young mom, my girls were covered on Medicaid, and I had Medicaid for a year. I got employer-based coverage. I got insurance
Mhm.
through them, and I transitioned off, right? Medicaid is for a lifetime or it's for a moment in
Mhm.
someone's life, and it
Mhm.
needs to be there to protect people. It's really important.
And I have Medicaid in my family too. My aunt, who has now lived to a very robust 91 years old, started to run out of the savings, did not anticipate maybe that she was going to live such a long and healthy life, and is getting supported on Medicaid with her assisted living. So, yes, there is so much more Medicaid out there. I think that people don't necessarily understand how many people are benefiting and using the service today. So, that's a great misconception. Any other favorite kind of things that you hear all the time that are a little bit off base?
I don't know. I think it's just the fact that
Mhm.
people, I'll go back to the fact that both you and I have personal stories of Medicaid, and
Mhm.
most people don't realize this, but over 50% of adults at some point in their life have been on Medicaid. And if you include kids, maternity, and long-term services, it's close to
Mhm.
2/3 of people today in this country have
Mhm.
been on Medicaid at some point in their life. And we just don't talk about that enough, to be honest with you. It's not it's not a low income program. It's America's safety net, and it's there for you at different
Mhm.
moments of your life. And we probably just need to say that better and more often, to be honest with you.
And it really there's bipartisan angles to talk about Medicaid, I think, from whichever side of the aisle you're on. On the more liberal, progressive side, this is when we're talking about universal health care, a stronger safety net, this is definitely Medicaid, right? Is expanding and working towards that kind of future. And on a more conservative, business oriented, like you said, Medicaid is something that saves communities a lot of money potentially, right? And it does, especially in California and a lot of other states, involve public-private partnership, which is a thing that people on the right might appreciate. Do you agree? It kind of sits in this like in between space.
Yes, 100%.
Mm-hmm.
I mean, Medicaid is a huge economy booster also, just to be clear. So it's tied directly from an eligibility to the economy, but it also significantly stabilizes the economy, right?
Mm-hmm.
So it provides resources to hospitals, to rural areas, to make sure people in those rural areas have access to healthcare, right? It is infrastructure at its best term, and definition of infrastructure is what I would say. And over time, people don't realize this, but a lot of health policy actually comes out of the Medicaid space. So Medicaid is one of the largest areas where you have behavioral health services. So earlier I mentioned long-term services and supports. It's also the driver of evidence-based programs for behavioral health, right? Which is really critical for everyone and huge right now in regards to how we are approaching healthcare. And people forget that that is often driven out of Medicaid policy. And yes, the private-public partnerships, majority of providers in Medicaid, if you look up statistically, are private or nonprofit, for-profit areas. And so these private-public partnerships are critical. The government is one piece and public entities are one part of the puzzle, but there is a lot of growth around tech solutions and all kinds of things that are really helping in this space, and oftentimes piloted and driven in the Medicaid space and then taken to other parts of healthcare, whether that's Medicare or the commercial side. And so, yes, that doesn't get talked about enough, that a lot of people in Medicaid say we are the kind of innovators of health, and we don't get a lot of credit for it, to be honest with you.
Yeah, and so we're in this moment of government shutdown right now related to healthcare and healthcare costs. So, we've talked about a lot of the things that we appreciate, and we're boosters of Medicaid, but there is progress that needs to be made or change that needs to happen maybe with Medicaid. What are the things that we're you're not saying right now in the moment of this shutdown, or not having clear conversation about when we talk about making some changes in the system?
Yeah, I mean, I think it's going back to kind of some of the things we've been talking about. Americans say that the number one priority for them is the economy. And the core of the government shutdown is about that, as well as including the cost of staying healthy as being a part of the economy, right? It's like we're separating these things, but somehow Medicaid eligibility and marketplace subsidies have been separated from that reality, when that is essentially what families are saying. When they're saying that the economy is their priority, it's because they need to afford everything from rent to food to being able to pay for their medical bills. Tying it back to what you brought us in 1965 when Medicaid was created, that was the core. It was an income level that couldn't afford the medical bills because they're otherwise were providing for their basic needs of their family. And so you intervene for a period of time, right? So it's funny how we've kind of disconnected these two things as we're talking about it. And so I think it's just, again, coming back and bringing those things together, because I'll just give you a statistic, for example. Healthcare costs are completely unsustainable, as we know. But today, the average annual cost for healthcare is nearly equal to one full year of the poverty level income. So just think about that. If you were to just take what it costs for a normal family to pay for healthcare today in the United States, it's equal almost 100% equal to what they earn for the entire year.
Yeah.
That
That
leaves you
is
no room to pay for things.
nothing.
That is why
Yeah.
marketplace subsidies and Medicaid
Yeah.
eligibility are at this core crux of the shutdown,
Mhm.
because we're acting like it's not a part of the economy when it's 100% the economy piece, but we're just talking about it as Medicaid or marketplace subsidies. We're not tying it
Mhm.
back to actual people's lives, or not everybody is, I would say. And so I think that's it. Just goes back again to
Yeah.
Medicaid is really America's safety net, and it's there to help be the backbone for families when the economy isn't in its best place, or when the economy
Mm.
needs to catch up. And
Mhm.
so that's why I think it's an important conversation, because it is tied to America's priorities, but somehow we're not talking about it as if it is.
Mm.
So
Yeah.
that's what I would say.
Like that. Yeah. I mean, I really think it's such an interesting area that there is so much good progress happening in Medicaid, but there is a big communications problem, right? With a lot of it and how we talk about it. And even, in California, we don't call it Medicaid, we call it Medi-Cal, right? And even some of that complexity adds on to why it is difficult to have a national perception maybe of Medicaid that is accurate
Yeah.
and reflects what's really happening across all these different states.
Yeah, in fact, when all of the changes were happening through the negotiations of the budget, one of the biggest things that you saw hitting the internet was everybody translating what is Medicaid called in your state. Because
Mm,
a lot of people don't realize they're even on Medicaid,
mm,
because it's called Medi-Cal in California, or in other states, it's called other names. And so when you're
mhm,
talking about that at a national scale, it
mhm,
doesn't correlate to families every single day. So you're 100%, it's a
mhm.
part of the PR problem as a whole on a national scale for a program that each state has tailored. And we want them to tailor it. It's why it's in every state. And so, but it does create communication challenges, as I would say, for sure.
It creates a those guys problem, right? Which I think is a problem with a lot of our discourse right now, is that there's always like those guys are doing this bad thing. And you're like, who is that? Like, who are you talking about?
Right.
Where exactly? Like, give me a specific name of what we're upset about. Let's like dig into it and be more specific. Is there a state, given that innovation where each state handles this in a slightly different way, is there a state that you think is really creative in how it's using Medicaid or rolling it out that's maybe not getting credit for it?
Oh goodness, that's a really
Mm,
packed question.
mm,
I would say, what I would say is there are a lot of states doing really amazing things across the board.
mhm,
That's usually policy driven, is what I would say. So,
mhm,
right, like you have like states who are really, really great at home and community based services and long term services
mhm,
and supports. Like when I think of some of those states, it's like Massachusetts and Wisconsin and some of these really innovative, states. But it changes based on
mhm.
what policy you're talking about and what you're really focused on. So it's a really hard question to answer, to be honest with you. I think that's what's so unique about Medicaid is that states cover different things, they cover different populations, and they approach it differently. But we all have very core similar problems. We just talk about them differently.
Mhm.
And so it's sorry, it's a hard
Yeah.
one for me to answer.
No, that's okay. Like you're saying, it's very complicated. We're trying to tell the positive stories. It's difficult sometimes to extract, one crystal clear campaign slogan for
Yes.
Medicaid across the country. So what are some shifts that you think would be the most critical in healthcare as, potentially we're at this moment of trying to create some change, some substantial change, really stabilize these issues that we have, especially around cost? What's
Yeah.
your wish list of magical changes you'd like to see happen?
Yeah. Yeah. I mean, I think that there's a few really good things. Like, for example, I think we should be supercharging primary care, right?
Mhm.
Everybody needs primary care. One of our largest issues is chronic disease in the nation, and primary care is at the core of that. And so, really doubling down on primary care, investing in that, investing in integrating behavioral health and maternity care, improving what it means to do team-based care. It's great
Mm.
that there's a lot of team members on a team, but we have to think about, does everyone know their role and responsibility? How are we sharing data across them? Because sometimes team-based care can also result in the patient telling their story 15 times to 15
Mm.
different team members on a team. So like, how do we reduce that? So I would really think about one, supercharging primary care is what I'd call it. The next one is at the core of what you're saying. Financing and Medicaid is definitely a topic these days. It was a core focus of HR 1 and making some pretty large cuts on that front. So really, I don't see how we don't move forward without addressing affordability and cutting administrative waste, to be honest with you.
Mhm.
So I do think that there needs to be a clear focus. But I would say, though, instead of just cutting administrative waste, which all administrative waste going away is good. However, I really want to focus on where's their administrative waste that, if removed and if those barriers removed, has a direct correlation to improved outcomes, right? Because there's a
Mm.
lot of waste that can be removed. There's even some costs that can be saved, but there's not a direct correlation to improving outcomes for people and patients. And that is kind of where I think we should have a core focus on that front. And also thinking about kind of how we pay a little bit differently. So
Mm.
a lot of times we talk about value-based care in different environments and payment reform and all these things. But I think we need to start paying for, instead of just paying for services, paying for outcomes. But I don't mean just tacking on a few quality measures to your capitation rate, or you have like 5% tied to it or 2% tied to it. I'm talking about, should we pay for healthy births? Should we
Mhm.
pay differently in regards to primary care? What does that mean to have supercharged primary care? Should we be linking it to how they're doing on chronic disease management, or a
Mhm.
reduction in low value care, which we know just wastes a lot of money in healthcare and actually isn't good for patients to be getting those services? So really thinking again about how we, pay for care. So those are some ideas I would have of kind of critical shifts, especially when you're being squeezed financially, and just because money's being squeezed in Medicaid, everyone's still going to expect outcomes to improve, right? So you have to kind of double down on some of those basic and foundational elements, in my opinion.
Yeah, and it's amazing. I mean, there genuinely is good news, seeming to be good news in terms of increased payments for primary care this week. A pretty substantial change that happened with reimbursement there, and starting to move a step away from the AMA system. It's fairly specialty driven of setting those reimbursement rates. So some optimistic baby steps on that side. And then I'll do a shout out to one of my favorite programs, which is mandatory bundled payments for joint replacement
There
surgery.
you go. I love
Which
it.
is one of my favorite programs. And it was, I mean, obviously that's a very contained use case in medicine of, going in for a knee replacement or hip replacement. But I have really seen in the, how many years did that get implemented? Maybe 4 to 6 years ago. It's hard to remember how long ago that happened, but I've seen a tremendous change in how that bundled payment has really changed the patient experience, has shifted the kind of follow-up care people get, has removed some potentially excesses that we had on the hospital side, bringing people home more quickly. So 2 points of light that we can celebrate today, when, good news is not always easy to find right now. Do you
Yeah.
have some favorite positive signs that you'd like to shout out?
Do I have, sorry, say
Oh,
that
some
again?
favorite happy news, positive stories of positive progress that are happening.
Yeah, I mean, what I would say is positive news, and this, I think for the first time with health related social needs, Medicaid is
Mhm.
finally starting to kind of break down the walls of healthcare.
Mm.
And why I think that's important, that's what I would say is positive news for me,
Mhm.
because for a really long time, we have built our entire healthcare system around people aligning with what's convenient for providers coming into facilities. And that works for a huge amount of people. But guess who it
Mhm.
doesn't work for? It doesn't work for some of our most vulnerable individuals. And so I get a lot of hope, is what I would say, from this idea of kind of breaking down the walls of healthcare, going back to our roots of healthcare, which was actually being in the community, being in people's homes, and really meeting people where they are, and kind of going a little bit more upstream. So that would be, I do agree, bundled payments are amazing, but I would say equally amazing
Yeah.
is rethinking about how we address health, how we think about health, and going a little bit more upstream to have great impacts in people's health.
So let's talk about CalAIM, which
Sure.
is a program that maybe a lot of people have not heard of specifically, but it's been going now for a couple of years. Tell us about CalAIM and what it's designed to do, and the sort of vision that here in California.
Yeah, so CalAIM has been live, like you said, for a few years. And, the hard thing is it's a very big program. It crosses
Mhm.
over all parts of the Medicaid program, but I'm going to focus on maybe kind of two core pieces:
Mhm.
enhanced care management and community supports. And essentially, it's taking some of your most vulnerable people who are experiencing homelessness, people who are in and out of incarceration, individuals who may be going into skilled nursing facility home, as an example, or need long-term services and supports, and providing them with interventions and services and supports that allow them to thrive, to sometimes change the trajectory of their life. So it includes anything from providing them a trio of housing supports, whether it's housing
Mhm.
navigation, or some of those services includes medically tailored meals, or to keep someone safely in their home and not be admitted to a SNF, it's providing wraparound services so they can stay safely in that home or be in an assisted living environment to thrive with their community, right? So it's really around interventions, both enhanced care management and additional supports to kind of work and provide services to some of the most vulnerable
Mhm.
individuals in Medicaid. And often those that are driving significant portions of the cost of
Mhm.
Medicaid. And there are some really good outcomes. We're seeing really good things in a number of areas. For example, the power of care management for these populations is showing really good outcomes by identifying some of these really complex populations. Sometimes, for example, in California, we'll just say in the CalAIM program, you get a card saying you're eligible for Medicaid. Oh, but you have to navigate, 7 or 8 completely separate systems. Your managed care plan does this. Oh, and the counties
Mhm.
provide behavioral health here. It's just really hard to navigate, which has resulted in a really complex system. And so the idea is taking those who do have to navigate a larger number of the systems and providing services. And I'll give you an example. Pair Team is an example of a really good ECM program that's using this combination of kind of mixed in-person and virtual visits. It's backed with kind of clinical access. So it's there reconnecting them back to primary care, again, getting them back to their core.
Mhm.
And it has these great technology solutions wrapped around it. It's reducing emergency department visits by 52%, reducing inpatient stays by 26%, and increasing appropriate outpatient visits by 21%. I mean,
Mhm.
that is exactly what we want the system to do, right? And we're innovating in ways that we hadn't before. Going back to Medicaid
Mhm.
being an innovator, we're seeing this kind of tech-enabled and clinical-enabled kind of care teams, both virtual and in-person, and outside of the four walls of an actual clinic or hospital,
Mhm.
really driving change in other parts of healthcare as well.
Mhm.
So that's an example, I would say, on that front. I would say CalAIM is also preparing California for an aging California. So California is large, a lot of people in California, and with every year, the aging population is growing. And a lot of the services in CalAIM, all those services includes things like home modifications or, again, keeping people in their home. That's building infrastructure across the entire state of California.
Mhm.
I think CalAIM Services has touched, 250 or almost 300,000 lives. It's a huge touch in regards to people enrolled in the program, really providing services. And if I can give one more example
Yes,
of
please.
what CalAIM is doing, um, obviously you can tell I care about this program, but it's building a continuum of care for people who are unhoused, and that's really important. So, for example, if somebody who is experiencing homelessness gets admitted to a hospital, before CalAIM, they could often languish in a hospital bed for months because a
Mhm.
provider would be anxious to discharge them to the street if they needed wound care or some types of follow-up
Mhm.
services. And one of the services that CalAIM provides, for example, is called recuperative care, and essentially is a step down from an inpatient stay, a skilled nursing stay. Sometimes it's prevention of going into those where from the emergency room you can move them there. And it's providing both a place for them to stay and heal with some clinical supports available to them. Um, and it's a step down. So it's getting someone out of an inpatient bed. But then while they're in those recuperative services, they can get enhanced care management that can help connect them to housing navigation services, other supports. They can get them connected back with primary care. They can get their medication under control. They can help stabilize them. So really, at the end of the day, CalAIM is really about breaking down the walls of healthcare,
Mhm.
meeting people where they are. Sometimes that means on the street or in the community, and providing them the support services to really thrive as humans, which is what we should all be
Mhm.
striving to do. So hopefully that gives you a little bit of idea of what CalAIM kind of vision was, but then how it's kind of come to light
Mhm.
in the last few years.
And a lot of that service is then provided by community-based organizations,
Yes.
CBOs. And so it's not necessarily being provided by a state agency or somebody who's working for the state, but it's being provided by like the local United Way or local women's shelter program. Is that right?
Yes, that's great.
Mhm.
Yeah, I mean, there's been a huge growth of community-based organizations coming in to do this work. And like we joked when we rolled out CalAIM many years ago, I said,
Mhm.
you're not going to, you hire a surgeon to do surgery, just like you're going to hire a community-based organization to help with housing supports.
Mhm.
It's not going to be the state doing that. And it definitely shouldn't be sometimes a managed care plan or just a primary care provider, right? You bring
Mhm.
the resources to bear that know that well, and you integrate it into the system. We're trying not to medicalize those services too, and there's always a balance there when
Mhm.
Medicaid's paying for it. But yes, community-based organizations. I actually think it's one of the biggest values of CalAIM is it has built a better relationship between the Medi-Cal program and communities, a far outreaching just primary care offices, hospitals, and the normal players who are in health, but these
Mhm.
other wraparound individuals. It's even, for example, I think it's Oben Health who's bringing preventative services to barbershops as an example,
Mhm.
right? So community health workers embedding themselves in the community, community-based organizations out there working on improving people's health. It's just the influence and touch that it has
Mhm.
had has been significant.
I love that. And I mean, that's one of the strengths and also challenges, I think, in the California healthcare system specifically, and probably similar to a lot of other states, but is that there are just so many players involved, right? And so, as a person who would qualify for Medicaid, I think that's a place, there's a couple different hurdles you talked about, the administrative burden of applying, right? But there's also, I think, a real burden of just the navigation of the system. And one thing I've noticed with my aunt too is that it's great because there are a lot more services towards her population, which is a dual eligible. She qualifies for a lot more. I have noticed that there's increased activity in terms of like poaching, right? So she gets a lot of calls from a lot of different organizations that want to help. How are you thinking about that side of yes, we want this to be a complex system that has a lot of grassroots coverage in our local areas, but how do we make that an experience for that patient that still like
Yeah.
they might have one person that they know they can always contact, right?
Yeah. Yeah, no, it's actually is one of the goals of CalAIM because the population we're talking about, as an example, they have sometimes individuals in Medicaid, if you have complex situations, can have like 6 or 7 different case managers. So
Mhm.
we're talking about one part, but it's also within the healthcare system, even when you have selected one, navigating it, everybody assigns a case
Mhm.
manager. And the idea behind enhanced care management, at least, was you have one quarterback and it's their job to coordinate with all of the case managers. And that's easier said than done, to be honest with you. It's
Mhm.
one of the most complicated pieces, but I do think it's an important one. I think
Mhm.
we also have to figure out how we communicate better directly to our Medicaid beneficiaries around how to navigate. So a lot of Medicaid agencies are actually getting better at these like cheat sheets or patient brochures that kind of help
Mhm.
break down complex systems. Here's who you go to for this versus this. And that's just challenging because even myself, I get a ton of
Mhm.
mail every single day, right? And what you read and what you don't. But I
Yeah.
do think it's still an area for improvement. I think Medicaid still has room to improve. How do patients navigate it seamlessly? How do we
Mhm.
make it easy? Maybe that's something AI can help us fix, to be honest with you. They're really good at kind of breaking down information. But I still think it's a huge opportunity.
Yeah.
Lots more work to be done there is what I would say.
Yeah, and I mean, those are the stories I think we're having our own personal experience with Medicaid is a real advantage. And I was talking to a young woman recently who was living in Las Vegas, came out to UCLA to have had like a very serious case of leukemia that had spread to her brain, and she had a great caseworker, at the hospital. Social worker was helping her. Medicaid covered millions of dollars worth of treatment for her. In some ways, it was a really huge success story. But at the same time, she's a single parent to a disabled child. How did she, her big questions were like, how do I pay my rent? How do I get my kid in school? How do I make it so that my child is not taken by CPS, like those kinds of services? And I think there's so much opportunity for Medicaid patients to have that focus on some, yes, we're making big steps on some of the big things, which is fantastic. Love those positive steps. But still trying to see that whole person, not whole person, but even whole family, right? Of what does this person really need? And is there somebody who can help them coordinate across like this very complex system in this big complex state, right?
Yeah. Yeah. I mean, I think, for a long time, healthcare has been so focused on the systems, the processes, the benefits. We
Mm.
forget there's like a person and a family in the middle
Yeah,
of all of that,
yeah.
right? And we make it convenient for us, which is why we're okay with 6 different case managers reaching out to
Mhm.
one person. And so, yeah, I mean, I do think healthcare overall is way too complicated, and Medicaid's probably even more complicated than
Mhm.
that because of how it's funded. And so, it's definitely something I think everyone has to keep focused on, reducing the
Yeah.
complexity. It actually drives the cost up too. That complexity that we're talking
Mhm.
about, the fact that
Mhm.
you're paying 6 different people, and we
Yeah.
are, not
Yes.
just California, but
Yeah.
all states are paying multiple different case
Mhm.
managers or
Mhm.
staff time in different areas
Yeah.
working on similar patients and people, right? How do we start simplifying our systems and processes and benefit
Mhm.
design around people, and not what's convenient for the one who's billing it, is what I would say.
Yes.
And it's definitely a reflection, not just in Medicaid, Medicare, and commercial and everywhere, that needs to definitely have some reflection.
Yeah. I wasn't on Medicaid, but when I was born, my daughter was discharged from the hospital before I was, and we had to pay out of pocket for a private nurse. And I mean, just you'd think that seems like a pretty like standard situation that might happen in a maternity hospital, right?
Definitely.
Some common sense. Let's work towards it. All right. So final two questions. We just have a few minutes here left,
Sure.
but talk about, what keeps you going on remaking medicine? Because, you know, you've had a long history in this, longer than me. We all have those moments of like, should I just go work on something else? Should I go work on like solar panels? Like, what is like the thing I should be doing instead? But like, what keeps you going in terms of, doing this work and continuing to see, potential for progress ahead?
Yeah. I mean, I think for me, I don't know if I'll ever leave Medicaid. I'm a pretty hardcore Medicaid person. Almost my entire career in it. I just think it's so meaningful. And to me, it kind of represents bringing, again, like we were just actually talking about, like how do we bring patients back in the center of healthcare, and
Mhm.
think about those things. It drives me every single day. I used to tell my team, we don't want to tell someone sorry for that issue. We want to say we thought about you before you got here. We designed the system for you
Mhm.
before you got here. Not sorry about that complaint. Let me fix that and get back to you, right? And it's just changing our mindset. And I think it's what drives me. It's remembering that health is not about treatment. It's about
Mhm.
healing and living. Like these are people's lives, right?
Mhm.
I often kind of go back to that, who the World Health Organization definition of health, which is like health is a state of complete physical, mental, and social well-being, and not merely the
Mhm.
absence of disease, right? Like the
Mhm.
whole point of living healthy lives is that people can thrive in their communities and be connected. It's not just about treating diabetes or
Mhm.
treating, hypertension. It's about all of the pieces. And I think that's what keeps me going, to be honest with you, in this work.
Mhm.
There's a lot of room for improvement. So I will have a job for the rest of my life, is what I would say. But I really come to this work for the people that we're meant to serve. And I'm humbled by being able to influence that in certain ways. I also tell people I'm very aware of that I may have contributed in my career
Mhm.
pathway at some point to some of that complexity or burden, right? And so it's also my job to then
Mhm.
think about how we can fix those things moving forward. So that's what keeps
Mhm.
me going, I would say, in this space, to be honest with you.
I love that. Yes, we're all part of this healthcare system. None of us, is like a perfect angel or a demon. We're all just trying our best to create a system that functions, and there have been missteps along the way. But, this is an entire system full of people who really are trying. Very vast majority of everybody who's really trying to do good work for people in healthcare. So I appreciate that. And then finally, is there something that you want to recommend that you're either reading now or that you feel like is really a foundational text for people who want to understand your perspective on the healthcare system?
I'll just go with what I'm reading now. I actually
Okay.
just started reading it, but I'm reading Cassie Kilman's The Art and Science of Connection,
Oh, okay.
and I think it's really important because we talk a lot about physical health, we talk a lot about mental health, but this
Mhm.
social health aspect I think is really really critical. And she kind of dives into how social health and connections with people and relationships are just as important, if not, no, she will actually say equal is what I would say. I haven't gotten to
Mhm.
do this part to lead healthier and happier lives. And so I'm really enjoying the book. I'm not done with it yet, but from where I am, it's about really giving us like resources and tools to think about that. And I just think it's really important, to be honest with you. So as a reflection, my husband's great grandma lived until like 98, and we
Mm.
would often say, why did Nana live so long? And the number one answer we got from family was, well, she went to the church every single day. She volunteered in her community, and every single person in that neighborhood knew who she was. She would always
Mhm.
walk around. She was fully connected. Like her relationships were
Mhm.
so strong. And so I think it's a great book so far. I'm hoping to wrap it up soon, but I would just give it a shout out because it just helps you think about things a little bit differently, helps you think about the importance of connection and relationships and how it actually impacts your health in very real ways. So that's what I'm reading right now.
I love that. Yeah, that's an incredible book. And that whole world, we've done some work with Project Unlonely, which is Dr. Nobel out at Harvard. And we had Chris from Arts Pharmacy here on the show before talking about social prescribing and arts prescribing. And it does feel like we're at a moment, kind of where we were with fitness, maybe a couple of decades ago, of that becoming part of healthcare. This idea of community and talking to people and addressing loneliness and, getting out of your house, especially coming out of COVID. I think we all need a little extra push, right? To be out there and to realize that, it's, the price of that annoyance is worth the value of being out and being in your community and being connected with everybody. And what a wonderful way to conclude our talk together, because I'm grateful that you came out virtually to talk with us about Medicaid and specifically in this moment. And I'm just so grateful for the work that you've done. Like we said, there is so much good that Medicaid is doing, has done, and also so much more that we could be saying and understanding about how it's working and thinking about, those lessons from all across the US of everybody who's approaching it in different ways, to hopefully create a new generation of Medicaid ahead, that will deliver a lot of value into our community. So thank you so much, Jacey, for coming. I really appreciate it. And I know that you're very busy, but people can find you on LinkedIn if they have any
Yes,
questions.
they can. Yes, they can.
Wonderful. Thank you so much.
Yes, thank you.